Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
My name is Myla Reizen, and I with me have 300 individuals that are going to introduce themselves as well. I'm a partner with K&L Gates, focusing on healthcare, and I do both the acute and post-acute side. And my practice is largely on the regulatory, investigation, compliance, as well as corporate integrities with a unique area. In terms of the specific topic we're covering today at nursing homes and care facilities, I spend an extensive amount of time providing resources and information to this community during this pandemic. And Paris and I both thought it made sense, another one of the speakers here is going to be introducing himself, to really talk about what's going on between the United States and Australia and talk about a comparison between the two. And what we wanted to do was also not just talk about it on our side, but also bring in some very nationally recognized quality consultants with us that you're going to hear from that are going to talk today. So with Paris, do you want me to turn it over to you for you to give your introduction, please?
Thanks, Myla, and good evening over there. Yes, my name's Petranis, and I'm a partner out of our Melbourne, Australia office. And like Myla, I focus exclusively on the health and aged care sectors. It's the only areas I do work with. And again, like you, Myla, I'm very much regulatory, but also with a commercial bent. I've been working in the aged care industry, and in particular residential aged care, for 20 years now in Australia, and have a lot of experience over that time. COVID has thrown a number of challenges forward for that industry, but in Australia, as Judi and I will touch on, we've also had some other challenges in the last 24 months in that sector which are impacting. So we're looking forward to a really great discussion.
It sounds great. And then Bruce, do you want to take it from here and kind of give your overview of what you do? Bruce and I have worked together for almost 15 years now, back and forth. So we've been in the quality space, both in the hospital, in the physician side, and now the post-acute side for a number of years working together. It sounds like you have the same rapport with Judi, so it'll be interesting to see the camaraderie here.
Well, thank you, Myla. It's a pleasure to be here with everybody. I'm glad to be working with you and talking about this important subject, because we know that a lot of the issues with COVID relate to our post-acute care, long-term care arenas, and we want to make sure that we can help advance the quality and the safety in those environments. I'm the president and CEO of Cynosure Health. We're a national consulting organization that we're all about quality. And I think improvement is our DNA. What we want to do is to say that we know that it's a continual journey, and we'd like to help people accelerate. We can go faster. We have the tools, we have the know-how. We can go faster at how we improve in this country, and that's what our job is. So I'm delighted to be here with everybody.
And then Judi, we look forward to hearing your background too. It seems quite extensive.
Thanks, Myla, and good evening to everybody. I live in Adelaide, South Australia, and I work for a national consulting firm, Ansell Strategic. My background is I'm a registered nurse, and I consider myself to be a career aged care nurse. So we provide consultancy and advisory services across Australia and New Zealand. I'm originally from New Zealand, so I have that background as well. And we really, our work is solely in the aged care space. And our aim is to help our clients to improve and, like Bruce is saying, to really accelerate how they do that, and to do it with confidence and in a person-centred way, so that we support, better ageing for older Australians. And I'm really happy to be here today talking with you all. And I think, this is challenging times. And I think this really sets the scene for how the sector can move forward and take confidence out of how well we've adapted or are starting to adapt to this new environment.
Okay, great. Thanks so much, Judi. And we're just all so excited, I think, to be able to talk about this topic today. It's an unfortunate sort of topic that we're talking about, but I think it'll be very interesting to have the dialogue back and forth. So the first area I think it'd be helpful to cover is just kind of an overview of where we are right now, where we started and where we are, just a little bit of background. We'll first start on the United States side, just give some numbers and just a little bit of background. And I think in terms of when our first reported case was actually in Washington State in February. And then over the next 3 months, the numbers have really grown significantly in the United States. Today, an article came out that there has been over 40,000 fatalities in the long-term care sector. That's including the workers and the residents. So those numbers are very significant, obviously. And in terms of the percentages, is that on the long-term care side, it represents approximately 43% of the COVID-19 deaths in 40 states. And that is data that just came out about a week ago. And then when you look at the United States, we have obviously a huge geographic area. It really has impacted all of the states. And when you look at the data for the different states, is at least 26 states are saying half or more of their total deaths are in the long-term care facilities, which is significant. So recently there was a federal rule that was put in place talking about the reporting of the data. And now there is a requirement that the data has to be reported to CDC in a specific time frame, in a specific format. And also it has to be reported to the families, the representatives, and the residents in a specific time frame in a certain format. So this was a recent rule that was put in place. So it'll be interesting to see the specific reporting now that we're going to have that data. Prior to this rule, the CDC has been reporting on a rather infrequent basis. I don't know if you agree with that, Bruce, but it's very infrequent. And then additionally, on the state side, it's been less than consistent as to how the information's been reporting. So Bruce, do you want to add anything on the background side?
Sure. So we know a lot about this virus, the COVID virus, but we don't know a lot. We're learning so rapidly. And in all my many years as a physician, this is one of the places where we've learned a whole lot in the past several months. So we know one thing that's really important. It's pervasive. Myla talked about all the impact across the country. We know over 6 million people in the world have been infected with this virus in just a short period of time. And we know that in closed, intimate settings like long-term care facilities, it's particularly virulent, particularly aggressive. The other thing we know we have a lot of great evidence and statistics on is that it affects the aged much more. So the younger you are, you actually have kind of a resistance to it. And the older you are, and especially if you have any kind of chronic disease or frailty, you're at great risk for the infection and for complications of infection, including death. And that's just disproportionate. Most of the other things we have don't have that kind of effect. In fact, many of the other viruses affect the youth, the young children and babies, as much as they affect the elderly. And we don't see that with this one. So it's a really virulent, aggressive virus that is behaving ways that we haven't seen before. But we also know that it is something that we understand some of the aspects of, and we can do activities and infection prevention that will prevent its spread and how we can manage this and mitigate some of the complications. So we're going to talk about that as we go on in this podcast.
And I think now it'd be great to hear on your end, Paris and Judi, your background and where you are right now.
Sure. Thanks, Myla and Bruce. And look, that was really interesting, and it's interesting how our statistics marry up, even though we've been very fortunate in Australia that we don't have anywhere near the numbers that many other countries like the US have. But the statistical analysis is actually interesting. I mean, we had our first confirmed case in Australia on the 25th of January when we had a person returning from Wuhan, and we had another 3 people test positive almost immediately after that. And we had our first death in Australia on the 1st of March. But when you look at our statistics as at the 1st of June, we have 7,200 confirmed cases in Australia only, which is 7,000 too many, but still a good figure. And we've had 103 deaths out of that, which is a 1.4% rate. Where this becomes very interesting is when we overlay that with residential aged care. Again, we have been so far very lucky that this has not pervaded our residential aged care facilities too much at all. And again, as at using 1 June figures, we had 67 confirmed cases only in our residential aged care facilities. And of those confirmed cases, 37 were linked to one facility, which is over half of linked to just one facility. Where the figures get really interesting, though, is when you look at the COVID-related deaths, 27 people in residential aged care. So while the number of people with COVID infected in Australia in residential aged care is under 1%, it accounts for nearly 27% of deaths, which goes to exactly what Bruce was saying about the impact and the spread. We've been lucky so far that we have been able to keep it out. Our worst example was one facility in New South Wales, which was probably the first one that really got hit, where we had 32 staff and 37 residents who were ultimately infected. And I mean, as Judi can talk to as well, we've had a lot of scrutiny over that and a lot of people trying to work out why that got hit so hard. And at this stage, it's premature to have any definitive findings, but the 3 suggestions we've got got are, first of all, that, residential aged care facilities aren't really set up like hospitals with the same infection control type of structures. And we're not talking about policies and procedures. We're just talking about the fact that these are people's homes. So there's carpets, there's soft furnishing, there's all of those things. So that's been discussed. When it first hit in Australia, we also had PPE shortages. So people couldn't go straight to, the full gowns, shoe covers, masks. And a perennial problem in aged care in Australia, or a topic of discussion, is just adequate staffing. So all of those things are being considered. But again, touch wood, and we don't want to speak too soon, but subsequent cases where we've seen COVID appear in residential aged care facilities have to date been contained reasonably well, but we don't know what tomorrow will bring. And I don't know, Judi, if you have anything to add to any of that.
Thanks, Paris. Look, I think that's a fairly good summary of where we are at currently in Australia in the aged care sector. I think that we've been fortunate here that we've started from a reasonably good base, and I think that's largely due to the introduction of the new aged care standards which came in last year. I think that really has set the culture throughout the industry that we need to be doing better. We have a higher standard to attain, and I think it's built confidence in the sector that they can adapt and they can move forward. And I think people were much more responsive. I think they were quicker to respond than we may have seen, say, 3 years ago before we had the introduction of the new standards. I think people have been able to mobilise really quickly and have been able to make good decision making as they go. Just on the use of PPE, and this is quite an operational aspect of it. One of the things that we have seen is that we largely deal with unqualified staff. But even the qualified staff that we deal with in the sector, nurses in particular, we've noticed that there is not a good understanding of how to use PPE effectively. And I think that's perhaps been one of our, the issues throughout the aged care sector. We've been lucky that I think people have got onto this really quickly. But unlike, back in my day when I trained, I won't tell you how long ago that was, we did a lot of barrier nursing. So use of PPE, how to put gloves on and off, how to put a mask on and off, how to handle some of this equipment was fairly well known by us. What we're noticing is that a lot of the newer, younger, and I'm talking maybe sort of under 40, under 45, registered nurses do not have that level of experience in some of the foundations of infection control. They might know some of the concepts, but these are really, sort of particular techniques that you need to use. And I think it took us a little while to really understand that and to start to get on top of how do we not only get our qualified staff doing it effectively, but then how do we train our unqualified staff, and to get that to become, an unconscious skill that they have in how to do this. And I think, throughout the sector, it took us some time to get to that point, but I think we're there now, and we've got good supplies of PPE now as well. So I think that's been really helpful.
Yeah, and when you're talking about, you talk about standards, is that during this time, how has the government provided different guidance, and have you seen a lot of surveying during this time? And also, what are your thoughts on self-assessments? And I think that, Paris, maybe you and Judi can take this one first. I think it'd be interesting to hear as a follow-up to what you just said.
We've had a lot of guidance from the federal government. So one of the advantages that we've got in Australia is that aged care is a federally managed system, shall we say, federally regulated. So no matter where the aged care facility is located across Australia, we all work to the same standards. We have the same funder. We have a very sort of unified, if you like, approach to it. And one of the things that we saw in Australia from very early on is that we had literally one voice talking about COVID at the national level. So all of the announcements were largely made by the Prime Minister with our Chief Medical Officer. And that approach was grounded on a national cabinet approach, which was the cabinet members were all of the premiers from each state. So we had literally one voice, one message across the entire country. And that certainly filtered down through to aged care, being a federal funded system. We had the same one message. So whatever messaging was coming out applied to everybody. So I think that was one of the advantages. What do you think, Paris?
I totally agree. Aged care being a federal jurisdiction helped. We also had unprecedented cooperation between the states that are responsible for healthcare with a national cabinet, as Judi said, which meant that we have had some differences but very, very consistent messaging and expectations, which really set the scene and I think facilitated compliance. We've also had our Department of Health and our Quality and Safety Commission giving very regular updates. I mean, I know, Judi, we were talking yesterday when you said there were some days you might get 4 updates about COVID, but at least it was setting the scene. And I mean, if I just go through just a few of them to give an example without wishing to take up time, our Department of Health will send daily COVID updates every single day. And those could be about how to use PPE, how to test residents and workers, how to deal with pregnant aged care workers. Pretty much if an issue was front of mind, there was an alert sent out, which, also meant that sometimes they had to be changed because people were rushing, but at least there wasn't a lack of guidance. There were e-learning modules available free for aged care workers on COVID matters put out by the Department of Health. Again, covering, correct use of PPE, as Judi highlighted. It was an issue, people not knowing. So that was addressed as much as it could be. There were advice specific for visitors to aged care facilities. We had restrictions on people entering aged care facilities, which were encouraged at the federal and governmental level, which made it easier for the facilities to enforce. So we've had extensive guidance issued, which has been helpful. And Judi, I mean, we were discussing yesterday as well, our Quality and Safety Commission, which sort of oversees and assesses our facilities, has been out assessing infection control and also playing an assisting role in helping providers get up to speed. I don't know if you want to add a bit on that, Judi.
That's right. I think that's been really helpful, that the homes have had an opportunity to have that objective view of how they're going with their infection control, how they're implementing the guidance that's been put out. The government also has put out some tools that enables homes to assess their performance really in managing COVID-19 or the potential for having it come into a home. And that's been really useful. But the commission visits have, those clients of ours that have had those visits, they've found them really useful, which has been great.
Yeah, and at a more general level, before we hand over to you, Bruce and Myla, we've also had a few other federal initiatives. So we've had, on the 12th of April, the government announced emergency response teams specific to aged care. On the 1st of May, they also announced COVID-specific payments and funding to help providers try and meet some of the additional costs. So it's been a moving feast, but it's been one area, I think, more than others, where there's just been a very unified front and people have had the same goal in mind, which is to try and minimise this impact and get everybody through it.
That was a fascinating overview. And on our side, we've actually had a significant amount of guidance that's ever-changing with the data that we're learning about the virus. And ours is coming from a number of sources, though. Ours is coming from the CDC. Ours is coming from CMS. And then also on the state level, there's some information. So I think the facilities are receiving a lot of guidance, and the guidance is quickly coming, and it's guidance that has to be processed quickly. And both of you alluded to this, though, is that there is a shortage in staffing. And so you have a lot of information that's coming quickly from different sources by facilities that are short-staffed. And so I think that has been one of the areas that has led to some of the challenges with the guidance that's come out, is just the rapid pace and the ability to implement it. And then I think also in terms of just some of the areas in addition to the guidance is that we have seen the surveying come out, and some of the results of the surveys continue to indicate that we had a survey that summarized the sort of focus surveys that are out there, and it was 25% of the findings of the facilities indicated that they had issues with PPE, and 36% had issues with the hand sanitizer. So when the government went in and reviewed the facilities, those are some of the areas that we're continuing to see issues with, and those are high numbers in terms of just those two areas. So that is just some of the highlights on here. And Bruce, maybe turn it over to you for what you're seeing in terms of the guidance and the quality side of what we're seeing.
Yeah, thanks, Myla. I think an important thing to think about is that word guidance, because a lot of providers have been used to guidelines that have been put out by a national organization. Guidelines tend to be a little more loose and more open to interpretation about their conflicting guidelines. What we're seeing in most of the guidance from most of the entities is they are really going in the same direction. There may be nuances that are different, but by and large, this guidance is going in the same direction, and they are established best practices, people that have been well worked out on these activities and the guidance. So it's a stronger recommendation. You can deviate if you absolutely have to for specific reasons that have to be well documented and explicit that make clinical sense. Not just because you don't have enough staff or not because you don't have some of the settings that you would like to do in a way. So guidance is a stronger word than guidelines. And this rapidity of change, as we learn more and more about what's going on in the virus, as we understand where it is focused and how we can combat it, both with medications and with other activities, these guidance plans and recommendations are changing rapidly. I mean, every week or two, we're seeing new things coming out. So it makes it a burden for the long-term care facility to stay caught up with it. How do you do all of those things? How do you know when the guidance has changed? So you actually have to have a person who's paying attention to some of those evolving science and the new changes that are coming out. One of the things that we're seeing a lot of too are myths. And so you go to any facility and there are people that are saying things that aren't true. They must have read it on the internet or they got it on some social media. And so the guidance is useful to debunk some of those myths or to actually test out whether, in fact, that's a recommendation from a well-known, reputable organization with science behind it. So myths and misinformation can actually distract the team. We'd love to see organizations quickly go to the guidance when there's a question and say, is that something that they're learning about? And find out from authoritative sources that this is the way to go. Let me give you a couple of ideas because I really, rather than spending the entire time going down each one of these recommendations, I wanted to talk about implementation of the recommendations. And Myla hit on something on the surveys that's really important. So a good example is that you need to have the supplies necessary to adhere to recommended infection prevention and control practices. That's kind of a no-brainer. First thing that the CDC does in their guidance under that is they talk about hand hygiene supplies. So a lot of organizations say, do we have hand hygiene supplies? Check. We've checked the box and we're moving on. What we talk about is, do you know they're being used and do you know when to replace them? Do you have a system in place that knows that these are being used regularly by the staff, either through observation or you can actually measure how rapidly the hand hygiene supplies are turning over. When you need to replace them, you can actually quantify and measure that, or you can do observational studies, a way to check implementation of that one. And then do you have a system in place that when you're low, you know when to replace it so that they don't run out and therefore can't be compliant with that. So just having a check the box won't be effective for that. Another example is creating a plan for managing new admissions or readmissions who might be COVID patients. And if you don't know their status, how are you going to do that? And it's one thing to have a plan. It's another thing to say, oops, somebody slipped through. We need to do a root cause analysis, or we need to understand how that could have happened, why the information from the discharging facility or from some other location didn't clarify that they had a COVID test that had been taken and they had symptoms that we should check. And so whenever you have a breakdown, you need to understand why that is and go into a root cause analysis, basic quality improvement type activities. And the final example I thought it was when you have somebody with a symptom of COVID, what do you do? And suspected COVID really in our minds today equals COVID. We're treating them as the same because we just know that you can spread these things asymptomatically. That's the one unusual part about this virus than many others. So treating suspected as COVID case is really important to be able to do. So I think also several people mentioned this notion that the entire staff have to be involved with this. It's not something that you can say a shift or a group of people aren't involved and aren't at risk for doing some of these things. So this is a team effort that needs to happen. And finally, the last thing part I'd say about implementation of these guidelines, it's not only what you do in the facility that matters, but your relationships with hospitals and other community partners that are going to make a difference whether you're going to have an outbreak, whether you're going to have something that rapidly goes through your staff and goes through the people living in your facilities, because it's these relationships with knowing what's happening outside that makes a difference with what goes on inside. So are local hospitals at risk, and therefore going to be transferring patients to your facility? And how much do you know what's going on at those local facilities that might impact you in the very near future?
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.